So I suggest we invite our friend from Baile de Bron, Laura Fox, Dr. Laura Fox, to make her presentation. Do you want to sit here? You have a little machine, yeah, it's here, yes. Yeah. Or you can stand if you want, yes, yeah. I better stand. Yeah. She fell down very recently, so she has a problem, yeah. Well, yes, no? Yeah. Because if I no, it's okay, yeah. Laura, she's working since many years with me and with MPN Spain and the foundation, and we have an activity in Central and South America because in MPN Spain we have a lot of South American patients, and we made a working group. We had a webinar with Central South American patients, and in that time I asked her to make a presentation of, to show patients what is MPN. Most probably, we are sitting here, we're nearly experts of MPN, but I know on a streaming there will be many new patients, and we still have to know what is MPN exactly. She made such a good presentation, but I said, we have to use that. So she will explain now the basics of MPN, and I think it's always important to know it and to hear about it. Please.
Okay, thank you for the invitation. This is a challenge, really, because I know that it's like I don't know how basic to do this talk. So if there are many things that you already know, sorry, we'll have a overlook. And if there is something that you may want to go deeper or to explain better, we can be talking. And if you want, I don't know, if we can do the question at the end, but for the ones that are here, we can do a talk. You can ask in the middle like that.
Sure. You interrupt when you have a question. Yeah.
Yes, my mother language is not English, obviously.
Well, we're speaking bad English, everybody.
Well, I try to do my best with that. Okay, I'm a hematologist. I work at the Valderon Hospital. One of my main interests are MPMs. I hope I can give you the message of what are they. So this is the kind of an index of what we are going to talk about. First, we are going to talk about what is the normal thing, what is healthy blood, yes, how blood is produced. Then we are going to talk of what myeloproliferative neoplasms are. We are going to talk about symptoms, quality of life, special characteristics of the main MPMs, general aspects of treatment. We are not going to deep it, but the idea of what we do in each of them, and the role of patients and family in these diseases. So what is healthy blood? So blood goes around the whole body through the vessels by the pumping action of the heart. No? So we can get samples of the blood by a venipuncture. This is difficult, with the pointer. We take that blood for studies. We put that blood in tubes, and then we can, with special tubes, and then we put this blood into a spin. Yes, in a very high, quiet velocity spin, and then we can separate the blood in 3 layers. So we have the yellow layer that is plasma, that is mainly made by water, is 92% of water. And then there we have proteins, we have immunoglobulins, we have hormones, we have clothing proteins, yes? And then we have a very thin layer, a white thin layer, where the white blood cells and platters localize. And then we have this red part here that is around 40–45%, that is where red blood cells are localized. And that is what we call hematocrit, the percentage of these red blood cells that we found in this tube, okay? So there we have all the solid elements of the blood, yes? The red blood cells, the white blood cells and platelets, and then the liquid part of the blood. The blood is a tissue. Yes, we have the skin that is a solid tissue, and we also have the blood that is a liquid tissue. And where this blood comes from? This blood comes from the bone marrow, and it's a constant process. The production of blood is something that we are constantly producing all the elements of blood. In the bone marrow is a mixture. Here you have a photo of the bone marrow. This is when we do a biopsy. This is what we see in the microscope. This reddish area here is the bone. Well, I think I go with my finger. This is the bone. Here we see these little dark points are cells, and these white areas is fat. Yes, because we need fat to get energy to support the blood production. And all these cells are in a structure, are sustained by an structure that is made mainly by this bone, very thin little bones, and there we have very other thick areas of bone. So here we find the stem cells, that the stem cells are the one that produce all the other mature cells. So these stem cells have the ability of self-renewal, so we don't run out of stem cells. That's why we can donate stem cells for transplants, and we don't run out of them. These cells proliferate and differentiate, so they choose which of the mature cells of the blood they are going to produce. So from the stem cells, we have progenitor cells that will give rise to the white blood cells, other ones that will give rise to the red blood cells. Yes, this is a decision that it's a process of maturation that these stem cells go on. And where is the bone marrow? In children, it's almost it's inside the bones, in older bones. But as we get older, this gets to the central area. We have bone marrow in the ribs, in the vertebrae, in the big long bones, like in the legs, arms, yes? So there is where we found the bone marrow. So this process is a contact process, but it's not something that goes on all the time. The body gives signals to the bone marrow and say, hey, I need red blood cells, I need white blood cells, I need platelets. It's not something that goes on with no control. It has a very strict control by signals to the stem cells to say, I need more, go on, produce, proliferate, maturate. So this is the way that it goes. So what are the neoplasms? We have seen what is normal. So now we are going to see what are MPMs. MPMs were first described in the 1950s as syndromes. They were called myeloproliferative syndromes. By that time, they also were considered rare diseases that they say, well, it's a problem with the stem cells, which produce an excess of mature cells. They saw that they produce an excess of red cells, platelets, white cells, but they didn't really know what was going on there. So thanks to the investigation, we now know that chronic myeloproliferative are not syndromes, they are neoplasms. Okay? Why they are neoplasms? Why this bone marrow proliferates in excess? Because they have mutations. Mutations are alteration in genes, and genes are genes are inside the cells, and they are like the instructions for that cell on how to work. Yes, genes tell the cells, they express and say, you have to proliferate, you have to differentiate, you have to stay calm. So when we have an alteration in these instructions is when we have problems. So these mutations make the cells to have an excess response to these signals and an excessive proliferation. So in MPMs, so we get the idea of how they work. These mutations change the normal functioning of some proteins especially related with proliferation. So in normal cells, what we have is the body gives signals, that signals are growth factors, hormones, yes, that gets to the cellular wall of the stem cells and tells the cells to start division and start proliferation. So you can imagine it's like a switch. So when they receive the signal, the switch gets on and the cell starts to proliferate. When this signal is gone, because the body doesn't need more cells, this switch goes off. But what happens in MPMs? This switch is always on. Why? Because the instruction to make that protein is strong, and it makes the protein that is always on. And so the cell is always proliferating. It doesn't care of what the body says. I don't need more red blood cells. I don't care. They still go on. So what are these mutations? Well, you know that we are talking here today about Philadelphia negatives MPMs, because MPMs, there are another ones. Yes, we have the chronic myeloid leukemia, that is the Philadelphia positive MPM. Yes. So this was the first one that was discovered, the first alteration in the genes that was discovered, and that explained why MPMs were not syndromes, just syndromes, why they were neoplasms. So this was in the 1960s, not that far away, And this alteration in the chromosome, here in this figure, we can see these are cells, and these are the genes organized as chromosomes. Yes, we have this inside each one of our cells. So two scientific groups in a city in the United States called Philadelphia, these two groups discovered at the time this alteration, comparing healthy blood with people with these MPMs. So they discovered that they had an alteration in the genes that it was called Philadelphia chromosome because it was discovered in that city. That was a good thing because the surname of the scientific was much difficult to pronounce. So from that point on, we start classifying the MPMs in Philadelphia positive ones, that there we have the chronic myeloid leukemia, and the negative Philadelphia ones. And there we have many MPMs, but the most frequent MPMs are essential thrombocythemia, polycythemia vera, and myelofibrosis. And that happened in the 1950s and 60s, sorry. And it wasn't up to 2005 when we start finding out more information about the mutations related to MPMs, negative Philadelphia MPMs. And it was in 2005 was discovered the JAK2 mutation, 2006 MPL, and in 2013 calreticulin. And we still have around 10–50% of patients with MPMs that we don't know which is the driver mutations. Yes, we're still working on that. So these mutations are acquired. And what does it mean? That we don't get this from our parents. We can't say it's fault of my mother or my father. No, we acquire this, and we don't know why. If it is because of contamination, radiation, we don't know. We just acquire these mutations. Sooner or later, because we're starting to see that this is acquired at a very early age, but we don't know why. And this mainly affect the proliferation proteins. That is a very simplified way to see what MPMs are, because there are many other mechanisms that we haven't talked, but that involves inflammation, that involves many other mechanisms that make MPMs sometimes quite difficult to manage. And many times, because when we start talking about mutations, genes, it's something that very frequently patients ask if these mutations can be inherited. if I can pass these cells to my kids? What we have to look for it? And we don't have what we have is we cannot pass this to our children directly because these are acquired mutations. But what we see is that in the families, there are many cases of MPMs. Maybe there is something that we don't know exactly what it is, but in the same family, we can find many cases, many patients with MPM. And sometimes it's not the same one, because sometimes it's essential thrombocythemia, polycythemia vera, or myelofibrosis, but not the same one. So we have to take care, we have to do the normal blood samples we do during our life, but it's not something that we directly are going to pass to our children. So what do we know about symptoms and quality of life in MPMs? Well, symptoms are really like, when I was trying to think how to communicate this, is like we have to know that symptoms have these three characteristics that make them quite difficult. They are not specific. So we cannot say that pruritus is specific for polycythemia vera, because we can find them in myelofibrosis, in essential thrombocythemia. It's not that. So they can, all these three main MPMs share all the symptoms we are going to be talking about. And also, these symptoms can appear in other pathologies. So we can be tired because we have an MPM, but because we also have hypothyroidism. So they are not specific of the disease and not specific of each of the MPMs. They are also multifactorial. And what this means that if a patient has a myelofibrosis and is anemic, he might be tired. But if you correct that anemia, he still be tired. So we have to find, there is another process that is explaining that fatigue. It's not only the anemia, for example, it's also the inflammation, or it's something else that makes this fatigue so difficult to control. And also that these symptoms are not going to be controlled 100% when you have a normal blood test. It's not that because you are tired and we correct the blood test, you have a beautiful hematocrit, leukocyte, perfect, platelets, perfect, no arrows up and down, nothing, but you're still going to have the symptoms. So this is something important because, especially in the everyday communication, because sometimes you may feel worse than the day before, and you see all the arrows up and down, but maybe this is not really straightforward related to the symptoms. So we have to talk and we have to look there, where is the problem? And what to tell you about symptoms? Well, there are a huge range of symptoms. We sometimes, you might, probably you are asked about 10 frequent symptoms in a scale we usually use in the visits, but there's still many other symptoms that could be related with MPMs. And here in this graph, you see that this is the percentage of patients that answer if they have these symptoms or not. And here you have many symptoms, probably the more frequent ones: fatigue, abdominal discomfort that we usually see, especially in myelofibrosis, eating, that we've been talking a lot. That, as you see, for example, here you have in blue, myelofibrosis, in red, polycythemia vera, and in kind of green, yellow, you have essential thrombocythemia. So, as you see, you can find eating in any of them. But especially in eating, is more frequent in polycythemia vera. And so if you see the list, it's really, really long list of symptoms. But we need to work up each of them when you are talking with your doctor. Oh, okay. No, go back. And when you saw that list of symptoms, if we talk with people, we will find a lot of people without MPM that could have many of those symptoms either. So this was a really nice work that it was done in UK, but also in the States, that patients were given two scores of symptoms, one for them and another one that have to be given to a non-blood relative, to someone that doesn't live with them. So to the neighbor, to, I don't know, to a friend, almost the same age. So they both fill out the same score of symptoms. And what happened? Well, here it's a bit difficult to see this graph, but you see here you have a lot of symptoms. They were asked about all of them. Headaches, I don't think you see the name from there, but headaches, problems for sleeping, problems at work, mood, general activity, fatigue, everything. They were asked for a lot of symptoms. And in the dark black line, those were the controls. Those were the friends, relatives, so they do still have symptoms, the same symptoms. But what happened with the patients? They have the same symptoms, but they were more intense. So as you go, here is 0, that means that you don't have that symptoms, and here is 5, you have a lot of symptoms. So as you see, they are all tired, almost normal controls, but patients with NPM are more tired. It's more intense, the symptoms. So this is something important that we need to explain to patients, and also patients to their family, because I don't know, patients when they get home say, I'm tired, and the other one say, I'm tired too. But probably the fatigue you feel is worse than the fatigue people without NPMs feel. And this is to explain the third point we were talking about, symptoms. This is a study called REVEAL that include people with polycythemia vera only, that were treated with many different treatments. This was it was an observational study. It wasn't done by the pharmacs. So what they saw here, in these graphs here, we can see 2 bars, a gray one and a black one. And here we see the NPN-SAF scores that probably many of you might know. It's a score that it has 10 symptoms, and patient has to put from 0 to 10 if they do have that symptom. 10 out of 10 is a very, very intense symptom, and 2, 3, it's a very low burden symptom. And what happened is that all those patients, independently of the treatment, all the patients that were in complete hematological response, that was that the blood test didn't have any arrow up or down, it was all normal, they have 19.2 median intensity of symptoms. And those patients that didn't have hematological response, those that were maybe above 45% of hematocrit, they did have the same intensity of symptoms. So this is something important, because this explains why symptoms are not easy to control, because the medications we are using they are not all focused, they cannot control symptoms only. So we say, well, we are going to treat patients to get this objective, the 45%, to try to avoid complications. But this 45% may not be enough to control symptoms. Even 42, even 40 may not be enough to control symptoms. And why symptoms are so important and why we work on them every time a little bit more? Because these symptoms affect the quality of life. And it's not necessary to have a high symptom burden, yes, to be very symptomatic, very fatigued, to have a worse quality of life. Also, patients with a lower burden of symptoms, those are the ones in green, still have problems with the quality of life. Still have problems for work, for their social life, their family life, many other things. So still, well, I'm 3 out of 10. I have 3 out of 10 of fatigue. I have 5 out of 10 of pruritus. Would you say, well, that's not that much, but still, that low symptom burden has an impact on the quality of life. Sometimes this problem with symptoms, the quality of life, is difficult to communicate with your hematologist or the doctor that is seeing you every month or every week or whatever. This was a work performed by patient association, and it was quite interesting because what they say is they ask patients at the moment of the first diagnosis if they have any symptom. That it's the same if they have pruritus, fatigue, abdominal pain, problems for sleeping, whatever. So patients that have just received the diagnosis of myelofibrosis, 81% said that they have at least one symptom. And the same for polycythemia vera, for thrombocythemia essential thrombocythemia. They all have symptoms. And then they went back to their doctors and say, which percentage of your first diagnosed MPM patients didn't have any symptom? They did the question in that way back. So patients diagnosed with myelofibrosis, their physician respond that only 10% of patients didn't have symptoms. And that correlates pretty well because we see that 80% of the patients have symptoms, and the doctors say that 10% didn't have symptoms. Well, that's not that bad. But if we go to essential thrombocythemia and polycythemia vera, here we seem to have a problem. Why? Because physicians think that only that 40% or 50% of the patients don't have any symptoms. But look what they answer. They all have symptoms. So here we need to work out the communication, because if the physician doesn't know that the patient has symptoms, we cannot help each other. And we have tools for this. We have the MPMs. Well, this one is in Spanish, but there is in many languages. So we have this score that this can help us to communicate, or at least to start communication, because here we don't have all the symptoms. We have only 10, the 10 most frequent symptoms. We have many tools. We can have this in paper. We can have some in Spain, we have this MPM tracker that you can follow your symptoms. You can do this on your mobile and show it to your hematologist when you go to the visit. So all these kind of tools, you have these tools all around the world, and this can make us communicate better, yes, to know how we are going, how symptoms are going, are we doing the right thing, is there something else going on, not only my MPM? So we need to work on that. Now we are going to talk just a little bit for those that this is the first time you start attending these meetings. What is essential thrombocythemia, polycythemia vera, and myelofibrosis? So just a few points of each of them. Essential thrombocythemia is when the proliferation is especially focused on megakaryocytes. Megakaryocytes are the cells that produce platelets, because platelets are just little pieces of a cell. They are not cells, yes? So these megakaryocytes that we see here, these are big cells in the bone marrow that liberate little parts of these big cells that are the platelets. Yes, so in the essential thrombocythemia, the main problem is the overproduction of platelets. Usually, these are the youngest of MPMs, yes, but still the age is around 60 years old when they get diagnosis. But we do still have even 20% of patients under 40 years old that are diagnosed with essential thrombocythemia. Most patients are asymptomatic, but still they can have any of, as we saw before, they can have any of the symptoms of NPMs. Regarding polycythemia vera, the main problem is the proliferation of red blood cells. But here in polycythemia vera, we have proliferation of white cells, of platelets, everything goes up. But we really take care of the hematocrit because it's like the main representative cell of polycythemia vera, that it goes up 45%. Usually, it's also the median age of diagnosis is around 60 years old. Many patients don't have that. It's something that we find out in the GP's controls. They don't have symptoms, or at least they haven't thought about the symptoms. Maybe they thought that they have allergy to the water, I don't know, whatever. And they didn't realize that this symptom was related to this neoplasm. And what we said many times, there can be many other symptoms related to B. vera, but probably itching, especially aquagenic itching, is the most representative symptom. And regarding myelofibrosis, is the less frequent of these three main NPMs. It's diagnosed probably in a later age, 65, 67, but well, this is statistics. And what happened here is that this, you remember that when we talk about the bone marrow, I told you that this bone marrow needs to be sustained by something. This something are these these fibers. This is not bone, it's like special fibers that in myelofibrosis, they get thicker. So they don't allow the stem cells to proliferate properly. There is also an inflammation process behind all this. So these stem cells that we saw that they are in the bone marrow, they have to go somewhere else. And where they go to the spleen, they go to the liver, they go to somewhere else. That's why in myelofibrosis it's characteristic to have a bigger spleen. And regarding the treatment, usually we talk only about pharmacological treatment, but we need to start thinking in a more integrative kind of medicine. We need to start also talking about non-pharmacological treatment. And if in pharmacological treatment we have a lot of work to do, in non-pharmacological treatment we have even more work to do, because here there is not really a lot of serious investigation. So in essential thrombocythemia, I always start in the same order, so we have the idea. Which are the objectives of the treatment? We need to avoid thrombosis, we need to avoid bleeding, we need to reduce symptoms to improve the quality of life. These are the main things. We want to cure the disease, yes, we do, but we still don't have the tools to cure the disease. That's why we concentrate in these three objectives. How we get to that point? We usually, depending on the risk of the disease, the age, the problems you already have with the disease before the diagnosis. And so with that, we decide if the patient needs antiaggregation, that is to take aspirin or clopidogrel or something in that way. We need to start cytoreduction, not all the time. In some patients, not everybody with essential thrombocythemia needs to do cytoreduction, and this means to put the platelets in a normal value. Yes, not all the patient needs it, and what all patient needs is to control the cardiovascular risk factors, because the essential thrombocythemia is one more of them. Yes, so it doesn't help to have normal platelets, normal, all the lab normal, if we have cholesterol, if we have a non-controlled hypertension, if we have overweight. So we need to really take care of that, everybody. The other 2 points depends on the driver mutation, depends on the risk, depends on other points. In the case of polycythemia vera, it's quite similar because we need to avoid complications like thrombosis or bleeding that may be less frequent, the bleeding in polycythemia vera than in essential thrombocythemia. But as you see, we have the same objectives, to control complications and to reduce the symptom burden. And how we do this? Patients do need to be antiaggregated. In the case of polycythemia vera, almost all of them are antiaggregating, only those ones that are allergic to aspirin that we look the way to get another way to antiaggregate these patients. And we have another two tools. Phlebotomies, that is a bloodletting, is that it's a process like similar to when you donate blood, but that blood is not used for donation. It's just a therapeutic kind of donation. This phlebotomy, what makes is the hematocrit that we were talking since we started to go down 45%. And why is that? Because we know the community have done many studies, and it was a very important English work where they saw this, that if those patients that were controlled with the hematocrit under 45, they have least risk of cardiovascular or thrombosis complications, cardiovascular, stroke, less risk of that. Because before this study, some people have patients between 45 and 50, another hematology less than 45, another one more than 50. For example, in Japan, they don't take care of this study, and patients with PVRA are between 45 and 50. But it's a different population. So this European study make us, and also in the States, to have patients under 45. That's why this is the magic number. And with some patients, it's not enough, the phlebotomy. And in some patients, depending on the risk and other factors, we need to start cytoreduction. And there we have a lot of drugs to do that work. The Idria, interferon, ruxolitinib, we have another pharmacs, and probably we will have more. And also the cardiovascular risk factors, that is in the bottom, but it's not least important. I think it's one of the most important, the same with essential thrombocythemia. In the case of myelofibrosis, it's a little bit different. We also don't want complications, and we are taking care if the patient needs antiaggregation to avoid thrombosis, but here probably it's not the main problem, the complications, especially thrombosis. It's very heterogeneous. Probably you won't find many patients with myelofibrosis with the same treatment because it's very heterogeneous, and some of them need more treatment for anemia, other ones need more treatment for symptoms, other ones need more treatment for the splenomegaly, and some patients with myelofibrosis even won't need any treatment at the start of the disease. And as the time goes past and the illness progresses, they will need some treatment. And that's why it's something that we need to focus the treatment on the hallmarks of the disease. If the patient has anemia, symptoms, splenomegaly. And between all these treatments, we have at this moment only one treatment that can cure myelofibrosis, that is transplant. But transplant is not for all the patients because transplant is a very aggressive treatment. We can get good results from the transplant when we apply this treatment to the correct patients with a correct donor in the correct moment. So this is something very difficult, and there are many discussions about when is the moment, which patient, which donor. That is really important to get involved in these conversations with your doctors to see why you are not a candidate for transplant, and if you are, when is the moment to go on that. And why we don't apply transplant to essential thrombocythemia and polycythemia vera? Well, because it's a very aggressive treatment, and it won't get, it won't avoid, no, and it's not, it's a very risky treatment for a aggressive disease. Yes, for essential thrombocythemia, is a very aggressive treatment for a disease that has almost the same overall survival as a patient without essential thrombocythemia. That's why we don't talk in polycythemia vera and thrombocythemia about transplant. And getting to non-pharmacological treatments, where here there is a lot of work to do. There are many studies ongoing about this, but these non-pharmacological treatments are complements to the pharmacological treatment. It's not that we are going to get rid of aspirin by doing meditation. So it's a complement. But I think it's really important to have these complements, but we need to know if they really work, because patients spend a lot of time and money probably doing these kind of interventions, and we really need to know that they are effective, because if not, it's not worth it. But we still have many news about this non-pharmacological treatment. For example, the diet. The Mediterranean diet is a non-anti-inflammatory diet, and it was compared with the American diet. And, well, surprise, surprise, it works better, the Mediterranean diet, to control fatigue, for example, and to decrease complications. So these are all interventions, for example, to do exercise to improve fatigue, that we think, yes, but if I'm tired, I don't want to do exercise. But it works the other way around. If you do exercise, you improve fatigue. So this is something quite important to apply, and they are easy steps to do to improve the quality of life of patients. Also, for example, sleep therapy to improve the rest, meditation guides. This was quite impression, because it was a mobile app to do meditation, and all these kind of things that can improve different fears or different aspects of patients, that to improve the physical aspect, cognitive aspect, emotional aspect, that may help to cope with the disease and to improve the quality of life. And talking about investigation, I think nowadays, every patient, everybody needs to know what investigations are, because we need to lose the fear that this work can produce, the clinical trials or the different kind of studies. So we have mainly two different types of study. Those that are observational, that is what they do. They observe how the patient is treated and how it goes, and they don't do any intervention. And we have the interventionist studies. Those are the clinical trials where you receive a special treatment, yes? And why these clinical trials and the observational trials studies are important? Because they give us real-life information. For example, all these studies regarding symptoms that all these studies put symptoms in the main area of treatment for NPMs. If we haven't done those observational trials that I showed you before, we probably wouldn't know that symptoms in NPMs are so important. So that's why observational trials, this kind of studies is still important, although you don't see any change in your treatment. And regarding clinical trials, those ones, we have many different types of trials, and the objective of this is to get new treatments and to be sure that these treatments are safe and effective, and more effective than the one that we already have, because we don't want new treatment less effective. So for you to have an idea, usually it's take around 10 to 15 years for a drug, since it gets discovered, to get to the pharmacy. Yes, it takes a long time. Why that? And not all the drugs that are discovered gets to the end of this pathway. For example, for you to have an idea, if we start with 10,000 new drugs that are discovered in a lab, yes, that we think one of these drugs could be effective for treat anything, or PV, whatever, or COVID, or whatever. But only one will get to the pharmacy. From 10,000, only one will pass through all this process to show that it's safe, to show that it's effective, and better than the one that we have. So this is a big loss of time. And so we have the first time, in the first part of the process is when they work at the lab with this drug, trying to see how they can if this really can work with some, probably they work with rats, with different kind of reproductions of the disease to see if it is effective. Then we start the phase, I think it's called here. No. The phase 1 studies, phase 2 study, and phase 3 study. Probably you probably hear about this. The phase 1 studies, and the one that is the first time this drug is going to be given to a human, is the first time. So usually these phase 1 studies are with a very low number of patients, and they start with a very low dose of the drug, the new drug. And they start, for example, they give to the first 3 patients, and if nothing else goes wrong, they pass to the next step. They increase the dose. And with the phase 1 studies, the main objective is to be safety and to see which is the maximum tolerated dose. Then we go to the phase 2 study. And here, many drugs fell down because they produce toxicity that is not acceptable, so they cannot go on. In the phase 2 study, we want to still see that it's safe, but we want to see that it's effective, that we really decrease the size of the spleen, that we really decrease the need for phlebotomies, that we really improve a symptom, that will really improve the disease. And after that, by this time, from 10,000 drugs, we only have 5 that get to this point. And from this point, if there is no other treatment for this disease, some drugs get approved. But if we do have a standard therapy for that disease, we need to compare the standard therapy with this new therapy. Those are the phase 3 trials, when we compare the effectiveness of these treatments and we see if really it's better than the one we have. And from there, only one pharma gets approved. And once the pharma gets approved, we have what we call the phase 4 studies. That is that we keep an eye on it for a long time until we get bored of this new drug. Because we need to do a post-authorization surveillance to see that, for example, after using 10 years ruxolitinib, we don't have a new side effect. Yes. So it's a very long way from the lab to the shelf for each treatment. And yes, this one.
I just think this shows very, very nicely the efforts the pharmaceutical industry have to do in order to get to new products. Well, maybe 250,000, or it says here 10,000. It's too high, but it still shows the reduction of new molecules which are making to the end. At the end, we have only one, which means that the pharmaceutical company has to work on many products, and they don't have a security that these products are coming out. So I think this is a tremendous effort which our pharma companies are doing. And here it shows also how important it is that the patients are participating in the clinical trials. I think, after all the efforts which have been done by many physicians, researchers, we have to be ready in order to make these clinical trials, because at the end, only the clinical trials will show us if a product is effective or not.
It's the only way.
That's right.
No new drugs. And this is the last part of the talk. that I didn't want to finish without talking about the active role of patients and family in the disease. And every day we see that patients have a more active role. This active role is increasing, and evidence of this is this meeting, all the patients association work. Patients are getting involved. It's not that they just go there and tell me how many hydrides you have to take and goodbye and that's it. They really want to know why we are doing this, what is going to happen, what they really want to improve. They don't, and this is important, this active role has only advantages. It's not something that has to, it's not something that is going to bother the physicians, the other way around. Because the advantage is that if you know what you have, if you understand what you have, you will accept that, and that will adapt your life to that. Because if you cannot change it, we have to adapt. And that will be better treatment adherence, better symptom control, and especially better quality of life. Because if you have something that you don't know what it is, and you don't really get involved in taking the pill every day or taking whatever you have to do every day, doing exercise every day, it's really difficult to go on. And what do patients need to keep on with that active role? It's something that is not you have the active role and that's it. You don't lose it anymore. No, we need the family support or the caregiver support, whatever is close to that patient, to be with them, not against them. That is something that happens sometimes. And even when the patient can keep that active role, the family has to take on with that active role to improve the control of the disease. We need to have a good doctor and patient relationship. If you, this is something sometimes difficult because we don't choose our doctor, we don't choose our patients. We have to get well on, and sometimes this can be difficult, but we really need to work on that. And this is, I think, quite important for the chronic, especially for the chronic illnesses. Because if I have a flu and I go to the emergency room and I see that doctor once, and well, he doesn't like my hair, I don't like his runners, and that's it. But if we are going to do a long way together, we need to get on well. And we need to understand each other either. And also, we really need information. And this is a very delicate point because nowadays we can get to Google and we can find many things that they are not really well explained, that can drive you to a very, very difficult misunderstanding. So we need to go, well, here I put the Spanish ones, I know, but I know that these are all around every country has its own associations, physicians association, patients association, where you can get really good information about the disease. And also take this information to your doctors so you can get special explanations about them and to clarify points that you don't understand. So just to finish, is like, I think the main 4 points of this talk are that patients with NPM, still there are some patients that don't have symptoms, but most of them have a very wide range of symptoms. So we cannot say, no, this is not related with the NPM. I don't know. It's like, so we need to really work on this because all these symptoms impair the quality of life. They affect the physical, psychosocial, the emotional, the occupational function of people, so we need to really work on that. We talked that symptoms are not specific, multifactorial. They do not always improve in the same way as the blood test, for example. We need to keep on working in the active role of patients and families to improve the care of the health. And we need to keep on optimizing, and that is the responsibility of the whole society, not only the pharmaceutical or the hospital, but it's a responsibility of the whole society to improve the pharmacological and not pharmacological strategies to improve the management of MPMs. And I love this because I found it in Google, so, that a rare disease isn't so rare when you have it yourself. So I think this is something that quite important, that especially all the authorities have to think in this when they decide to help someone to do investigations or to help to get pharmacs approved, to many, or not only pharmacs, to get some non-pharmacological treatments approved. I think they really have to think about what this patient with Pivera said once. And that's it. Thank you very much for your attention. And if you have any questions, yes.